All right. Hi, everyone. Welcome, welcome. I'm probably going to give people just a minute here to pop in. I see people are popping in one at a time. We just hit 7 o'clock. So thanks for joining us. I'm Biz Breland. I'm going to be hosting tonight. You're here at VO Health's Menopause is having a moment. It's our time. So let's do this. I'm going to let you guys know that at the end of this, we are going to take some questions and answers. We'll get to as many of those as we can. So as we're talking, feel free to just drop those in the chat and I'll take a look at them as we're going and then tee those up for Dr. Miller when we finish. So thank you guys so much for being here. We are excited to bring this to you. Dr. Miller is just off the plane from her trip down to Orlando for the National Menopause Society's annual meeting. This year, the focus was on longevity, which is appropriate for our topics here at VO Health. I'm Biz Breland. I'm the GM of Women's Health and a couple other roles here at VO. So I've just helped to organize some of this and love working with all of our members. And I know some of you guys are here tonight and a lot of you are not members. So if you have any questions on that at the end, feel free to ping those over to me. No problem. So just a little bit of background as far as what we do here at VO so that you can kind of get an idea if you're not already a member. We really try to give people as much information as possible about their bodies and what's going on. So we like to think that we're kind of flipping the script on traditional healthcare or sick care, as some people might call it now, where we give people the power to understand what's really going on with their bodies so that they can act more proactively and be a participant in their own health journey. We have a team of physicians, functional nutritionists, coaches that help them along the way. We've curated blood panels. It's all included in our program, actually. And that yields over 120 biomarkers so that you can track your progress over time on your stats and your figures and your numbers. But more important than that, we do the body composition scan so that you could really understand what your body is made of, what you need to be doing to keep muscle mass. I know for women, as we age, muscle mass and bone mass are top of our list to mitigate against osteoporosis and all sorts of different risk factors. So we like to put all of this into action. We give you a wellness plan and we hold your hand all the way throughout the year as we go through our process and in an ongoing manner. So if you guys have any questions about that at the end, please let me know. But as far as our women at VO Health, I know traditional OB/GYN that Kelly's been in for years and years is really hyper focused on young women, fertility, and supporting mothers. But we've got another phase coming up. So we've got perimenopause, menopause, and many women are going to spend about 40% of their lives in menopause. So that's an important chunk to pay attention to, and that's what we're going to do tonight. I'm going to steal one of the lines from the summit that Kelly gave me, and it looks like women actually live longer than men, and we know that, but they experience about 25% more time in poor health. You're dealing with frailty, sarcopenia, things like that. And that's just not how we want to live the final chapter of our life. We want to extend our health span so that we're healthier for longer and thriving. So with that, I'm going to tee it up to Dr. Miller. We're thrilled to have her on our team. I've known her for many, many years, and we are excited to be able to be friends and working together in this effort towards improving women's health and overall health. So with that, Dr. Miller, I will let you do your tee up and take it away.
Great, Biz. Thank you. I think you could do this talk. You just did a really great job. And we're going to keep this kind of conversational. I mean, it's always a little bit weird when we're on Zoom here. We can't see each of your lovely faces. But we're going to try to do this a little bit more conversational so that you don't just have to hear me kind of go on and on. But please send your questions into the chat box because we can get to that at the end for sure. So my name is Kelly Miller. I'm a gynecologist now. Notice I didn't say an OB/GYN. I practiced obstetrics for 20 years, delivered somewhere around my 4,000th baby in the spring, and then just called it quits on that part of my career. For years now, I've been super interested in gynecology. It was probably the my favorite part of actually of my career, and that I really loved operating. But a few years back, I pivoted and just started getting a lot of questions about hormonal wellness and aging well, and that we didn't get a lot of training in that in our residency training. Maybe 1% of our time was focused on that, and so went back and did with more conferences and coursework and became just more invested in menopause and learning the data and the evidence. And so now I'm a national certified menopause expert. And then I also a couple of years back just wanted to learn more about obesity medicine and this epidemic that we have, and especially like midlife, because there's definitely some changes that happen midlife, and kind of how does that work in with hormones. And so I'm now board certified in obesity medicine, but I've been practicing about 23 years, and I'm really excited to be with VO. And with that, we'll just dive in. So as Biz said, I just returned our national society. It's called the Menopause Society, and if you ever want to find content that is evidence based, this is where you want to go. And, a key, like I thought a really interesting kind of key stat that they said, as far as like evidence-based medicine, there's a lot online. There's a lot out there. You can really go down the rabbit hole and follow people on social. And, the interesting stat that a study that was used and quoted, a good study said that 67% of the content online on social media is incongruent with evidence-based data. And then, the other thing with that also is 71% of the people that had the data, that was incongruent or was not accurate, had a financial conflict of interest. And I bring that up because it's important to have a team on your side, that's evidence based, that knows what the data is, that can counsel you. Because I do really believe if we counsel women, the pros and the cons, there's pros and cons to everything. It's not all a pro, that they will make the best decision for their body. And so the Menopause Society they have an annual meeting. It's partly clinical, it's partly science, and there were a couple things that fit in really nicely with VO as far as key topics, like our keynote speaker. The title was longevity medicine, and I love this lady. She presents a lot of data, but her main thing was our ovaries are not just a reproductive organ, that they really are a neuroendocrine organ. And how can we optimize our ovarian function really to help us live well? Because that's the key, is we want health span, not necessarily lifespan. I hope I live to an old age, but I really want to spend those years in good health. And kind of a tagline that kept coming up, this was there, in the meeting, not necessarily mine, but I love it and I want to use it like all the time now. And they kept saying the best intervention is prevention. And I love that, because whether we're talking about brain health, bone health, heart health, the better that we can do at preventing disease, the better we're going to live and spend more years in health span, healthy years. I also love this stat that was brought up. 90% of disease risk is actually due to modifiable risk factors, meaning we have control and power over that, which is really, really great, that we're not, we don't have to rely on drugs to treat things, that if we just really do that hard work, it's important, because it can make a difference. They talked about how healthcare is siloed, and what we really need is a more multidisciplinary approach, and that we need to communicate better as medical practitioners, as far as with our nutritionists, with our cardiologists. Like, we really need all hands on deck, and that people to look more at the full patient and not just their little slice of our healthcare. And so having that multiple disciplinary approach like we do at VO, I think is ideal. Another key topic was sleep optimization, which we talk a lot about, with VO, as far as looking at your wearables and what's the quality of your sleep look like. How can we improve deep sleep, REM sleep? But, lots of science on how important it is for our weight management, for our heart health, bone health, mental health recovery, and just all hormone optimization, cortisol, ghrelin, leptin. They also talked about, like, it's not just, do you fall asleep fine? Okay, do you sleep 7 hours? But they talked about sleep timing, the variability in when we go to sleep, the duration, and the quality being so important. So, first day, the whole day was about perimenopause. I love, menopause is definitely having a moment, but we're seeing more talk about around perimenopause in this space. And there's a lot of changes that go on between 35 to 50. It's not defined as one age. And that's one of the big changes in our society is the definition of perimenopause. We used to have this definition where you had to miss a period, you had to be more than 14 days late with your period every month. And that has really changed. And it's definitely what I see clinically, and that most women don't present that way in perimenopause. They have subtle changes to their period. And now that counts, meaning periods are a little closer together. They're a little bit different. They, last a little longer, a little heavier. But as far as what, patients feel, because, they can deal with period irregularity, but the biggest symptoms we see, the severe mood changes probably is number one, difficulty with sleeping number two, low energy and fatigue, and then that weight gain creep that starts. We can no longer lose weight. It just goes around our midsection, low libido, and feeling tired. And I really love when they were talking about, perimenopause mood issues, that exercise and light therapy was really, that was first line, as far as it's got great level one data and evidence that it can be helpful. In the data, exercise of only 90 minutes a week can be helpful. So it's 30-minute sessions, light therapy, sunlight best, but also, bright white light therapy can be really helpful for our mood. Hormones, estradiol and progesterone can be helpful for moods. And then we talked about, the antidepressant medications. No one really wants to go and having mood issues from hormone changes and get an antidepressant. And I totally understand that and get that. Obviously, if we can do things with our lifestyle and hormones, awesome. But there are a few medications that have really been looked at for perimenopause, and they've not been shown to cause weight gain. They've not been shown to cause difficulty with libido and issues with libido. And so, the three top ones that they talk about, bupropion, which is Wellbutrin, Trintellix, and Pristiq. So you've got options there. And I think another big theme of the perimenopause day was just that anticipatory guidance. And what I mean by that is that, I think pediatricians do a really good job at talking about hormone changes in puberty and what to expect, but no one talks to a 35, 40-year-old about hormones, and what's coming down the pike. And really having that counseling is important so that women know what to expect and that they can start to work on health optimization that definitely shifts midlife. I love this next slide. I know the quality isn't good. This is not my slide, but what I love about this is it highlights again, probably that number one complaint, 35 to 50, is just the mood fluctuation. And these basically are lines that show different, each colored line's a different patient and a different day of the month and what their moods were like. High, low, patients kind of quoted how they were feeling. And you can see it's just like kind of chaotic is what I would describe this as. But having the conversation about what we can do, to help as far as hormone optimization is huge.
All right, Kelly, now it's time for some myths to get us started. So, here's your first one. Menopause happens suddenly.
Yeah, so we all know that even though it's defined as like that 1 year past your last period, it's like, oh, we're there, we made it, we're done. Well, we're not done. And it definitely didn't just happen in one day. And we all know that. And so, we need to stop talking about menopause as that one day and then we're just like, that's it. But we need to talk about that gradual kind of lead up process, the perimenopause, and then, what that transition looks like, because those symptoms and concerns that we have are going to go on, for years and really maybe for the rest of our life. And so we need to, it's more of a gradual process that we need to talk about.
hmm And I feel like my mom's generation falls into this category. And really, the only thing I ever remember anybody talking about was hot flashes. And I think a lot of people think that that's all the only symptom you're going to experience. So tell us about that.
Yeah, hot flashes. A lot of women, when I say how is menopause, oh, I'm fine, no hot flashes. And I'm like, okay, well, how are your joints? How's your libido? Like, it's not just hot flashes. There's so many symptoms. Even like we talked about at meeting, the burning tongue syndrome, obviously the itchy ears, a lot of people talk about, but sleep disturbances for sure, super common. We talked about mood changes already, just the changes in our skin, hair, metabolism. And it's different from everyone. I mean, I do have some patients that sail through with zero symptoms, but the majority are going to have something, and it's not necessarily just going to be hot flashes.
Right. I've heard some crazy ones. All right. Now, this is a big one. This is kind of currently being debunked, I hope, but estrogen causes breast cancer.
Yeah, I put these next two sentences are just like, just conceptually, if we think about what does our estrogen level look like in pregnancy? Well, it's in the thousands, right? It's very, very high hormone time. And, if estrogen really led to breast cancer, why don't we see that during pregnancy? Because the breast cancer risk in pregnancy are very, very low. And then also, why do we see breast cancer in, the older population? The risk increases as we age, particularly after 50, and that's when our estrogen, our endogenous estrogen level is really low. And, since the Women's Health Initiative in 2002, we've not, the use of hormone therapy has been at an all-time low, and breast cancer cases have continued to rise. So that's just conceptually what I like to kind of point out to patients. But then what does the data say? We have lots of data in patients that have had a hysterectomy that are on estrogen only that it actually shows a decrease risk in breast cancer. So that one is definitely a myth.
Awesome, thank you. All right, and menopause treatment is only available or acceptable once you've already stopped having periods for a year.
Yeah, another one that's kind of one of my pet peeves that bothers me the most. I'll get a lot of patients that come in and they've just felt dismissed. They'll have their doctor that, served them very well for deliveries of their babies or, in earlier in their life. But then they start to talk about hormone changes and they're like, there's nothing for you. You're not menopausal yet. And I just, there are lots of things that you can do. And so that talks again about lifestyle kind of optimization and really trying to more self-care, more parasympathetic, nervous system activation. We talk about supplements for sure. I'll talk about that. We're always food first as far as where you get kind of your vitamins but there's definitely some areas that supplements are super helpful. And then hormone therapy can be helpful and used in perimenopause.
Great. And then finally, that hormone therapy is dangerous.
Yeah. So, there's again, hormone therapy isn't going to cure everything. It isn't without risk or, things that you should think about. But, by far and away, hormone therapy, used in the right kind of population and at the right time can be safe, helpful, beneficial for many women.
Great. And I think where are we right now? It's about 5% of the population that could be on hormone therapy is on it.
Yes. As
Yeah.
opposed to 50% in 2002.
Wow.
That's some work to do.
Yes, we do. All right, give us some more stats.
So I love to talk to this, like show this and talk on these points to patients because, it's still out there very strongly that hormones cause breast cancer. And everyone is terrified of getting breast cancer. And I don't mean to diminish those that have had breast cancer. That's not why I show these stats. But when you look at a woman or a patient, we've got to think more than just our breast health, right? We're more than our breasts. So we've, got heart attack risk and hormone therapy can be helpful, as far as our cardiac risk. And so 1 in 3 women will have a heart attack. 1 in 2 will die if they have a heart attack. 1 in 8 will get breast cancer. 1 in 33 will die if they get breast cancer. 1 in 2 will suffer an osteoporotic fracture. 1 in 3 will die if they have that fracture. For sure, cardiovascular disease, number one killer of menopausal women. 2 out of every 3 Alzheimer's patients are women, and 1 in 5 of us will have Alzheimer's and a 0% cure rate.
Yikes. All right, what can we do about that midlife weight gain?
I think again, really, so we had a whole talk which I really loved on just kind of weight gain midlife. What's the data say? What can we do? And that we gain weight is really kind of fact. On average, women gain 1.9 to 1.5 pounds per year in midlife. There are several things. There's hormone factors, there's aging, there's lifestyle. During midlife that we have to take into account. And then the aging piece of that, 3 things that I just mentioned, we do have a decrease in muscle mass. It just happens with age. And with that decrease in muscle mass, we've got to adjust our caloric intake. So our muscle mass, our skeletal muscle is makes up the main component of our metabolic rate. And so, that with a more sedentary, lifestyle, we don't need as many calories. Lack of estrogen. So we know hormone changes us. And we have an increase in our visceral fat. That's going to be that midsection fat that wraps around our organs. We get more inflammation and more insulin resistance. And so, sensitizing those cells to insulin is really important. So the way we sleep, again, there's a common theme. Sleep restriction does increase insulin, increases ghrelin, decreases leptin, those hunger hormones that tells us when we're hungry and not. So if we're not getting good quality sleep, then we see metabolically, changes. The other thing I really thought was interesting too was the sleep variability, meaning you go to bed at nine one night, midnight the next night. Those patients had more weight gain. If you didn't get good quality sleep, defined as deep and REM sleep, we also had more adiposity, more inflammation. The timing of our meals really matter. So, the data they presented was just pretty. convincing that breakfast is important. And we always heard that. And, I'm not saying, with intermittent fasting, obviously, I'm not saying that you have to skip breakfast, but I'm saying that maybe that window should be we eat a little bit earlier and then we cut off that eating window earlier in the evening. So eating later, definitely close to bedtime, also increased adiposity and inflammation. And that poor sleep led to, on average, an additional 250 calories consumed daily. Weight loss pillars of movement, nutrition, stress management, sleep, and relationship quality were the 5 pillars to optimize and work on to lead to weight loss. Tracking, our nutrition is the number one thing. So the data, try to tell patients this, that the data is really clear that exercise is not going to lead to significant weight loss. And I'm not saying exercise is not important, because clearly it's vital for so many things, our brain health, our muscle mass. So it's important. But when you're talking about just weight loss, weight on the scale, we've got to look at our nutrition and do a deep dive there and really clean that up. And tracking helps us, because a lot of us just underestimate what we take in. And so seeing what we're taking in and looking at the macros and the breakdown important. We can do that with VO2. We can interpret your wearables, and look at those macros with you. We want to manage menopausal symptoms. We've got to be sleeping well, so hot flashes, and just optimizing our sleep important. And hormone therapy. So estrogen therapy does not lead to weight loss, unfortunately. It's going to be scale neutral, but what estrogen therapy does for it helps to preserve our lean body muscle mass, and it decreases visceral fat. And hormone therapy and GLPs can work quite synergistically together and work well together for weight reduction.
Great. And I know Dr. Ellsbury at VO does a great job kind of helping people identify what their macros should be and helping them like kind of stay on that path. And you guys work so synergistically, I feel like, to put that together for people so they don't have to guess anymore. They don't have to be like, okay, I think I should be 1,500 a day, or maybe it should be 1,800. We know exactly what we're targeting. So that's so great. Thank you.
Bone health, it's not super sexy, but as we age, I love just to remind patients that, osteoporosis related fractures are more common than breast cancer, heart disease, and dementia combined. So, how's that for a stat? This is important, but nobody talks about it. It's still definitely the real silent. We may not have this at 50, but the things that we're doing in our 30s, 40s, 50s matter. And important, with any of these disease processes that I'm talking about, they don't just happen when we're 80 and we have that fracture, right? Or when we have dementia, we have that heart attack. They're starting years before. And that's why this is so important, is to start years before at prevention, and particularly with bone health. We've got medications that I can hardly talk patients into, and I get it, that they have side effects and risk. But the fact is they only help improve bone loss by about 6% as far as our bone mineral density. They're good, not great. And for sure, again, that prevention and doing things sooner than when we have osteoporosis are really important. Key factors that Dr. McClung talked about is that family history of osteoporosis and having a weight under 127 are going to predict that future osteoporosis. They really talked about early DEXA scans and really hit on that. And again, this is the evidence-based medicine. And if you follow our USPTF guidelines, it actually says you shouldn't have a DEXA until 65, which is really ridiculous. Why wait until we have those fractures in our osteoporotic before we scan women? And they, all the experts totally agreed. In fact, they thought more of an early bone density at 50 to get your baseline, so that we can help you be more proactive on that data. Estrogen therapy, definitely protective, as far as preventing, it's an FDA approved indication to help prevent bone loss. And using higher estradiol doses, when that bone is rapidly turning over, which is 5 years before menopause and 5 years after menopause. That 10-year time period around menopause is when our bone is declining the most rapid, and then it kind of levels off. And so hitting bone health during these years, vital. I love this lift more. You can look it up, because if you want the exact as far as deadlifts, squats, overhead presses, and chin-ups that you needed to do, this is a great study that they quoted that I read, and it was all about heavy lifting. So you might want to do it supervised. It depends on your activity level, but we've got to lift heavy to really improve our bone density.
Awesome. Thank you.
Cardiovascular health, number one killer of women. one tip thing that I learned that I really, love the data is that we really need to do a better job at taking an obstetrical history because those that had preeclampsia, infertility, gestational diabetes, preterm delivery actually had an increased risk of heart failure and heart attack. Poor sleep, increased risk. White coat hypertension, a lot of patients come in, their blood pressure is high, and they're like, oh, I just have that. It's actually not a benign thing. If it's that in a doctor's office, what is it when you're, well, maybe at the grocery or doing things that are a little stressful, and having that home monitor and having somebody really interpret and look at that with you, important. Optimize blood pressure, lipid levels, diabetes, midlife. We do this at VO, but they talked about how important checking a lipoprotein levels. That's that hereditary protein that's so atherogenic. We need to know that result. They talked about CAC score, which we also do VO, which I totally love. That's a coronary artery calcium score. It's just helpful for risk assessment. How serious do we need to take the elevated lipids? Do you have disease there, plaques in those coronary vessels? Then 90% of risk for heart attack due to modifiable risk factors.
And here's
Eight
some more.
pillars. Oh, I'm sorry, Biz.
Yep, here's some
Um,
stats.
Yeah, these eight pillars are really important. Blood pressure under 120 over 80, your non-HDL cholesterol under 130. Mediterranean diet has the best data behind it as far as what's going to help our heart health and our brain health, and actually sleep data they presented with Mediterranean diet. They're big on that. Physical activity, we know moderate intense exercise at 150 minutes a week is our goal. Trying to keep our blood sugar under 100 or A1C under 5.7, no smoking, and just adequate quality sleep of 7 to 9 hours.
Yeah, that's the key, the quality, the rim and the deep and the combo.
That's
Great.
right.
Yeah,
So, hormone therapy, risk benefits, need to be individualized for the majority who initiate therapy in the ideal window of opportunity. Benefits are going to outweigh the risk. Not a fad. This is science. It's equitable healthcare for women. Important to have a conversation about hormone therapy. If you choose not to use it, you're past that window and you're not on it, that's okay too. Just that knowledge of kind of what's happening during menopause and after is powerful because we can optimize key areas like lifestyle, exercise, nutrition, and there are definitely non-hormonal options that can help you, whether it be with sleep or hot flashes. Women's health is not just reproductive health, but it's, sorry, can you go back one slide?
yeah,
All women should learn how to menopause so we don't have to suffer as our mothers did.
exactly. It's all about extending that health span.
Yeah, and I love this graph, which basically on the x-axis is our age. The y-axis is our functional ability. The different colored lines, so blue is those that had an optimized lifestyle, so nutrition, movement, optimize, and you can see we do pretty well. Those even that don't have that optimal lifestyle, we do pretty okay in our 20s and 30s, and then we just fall off the cliff. Starting around 38 to 40, and that's why optimizing things so that we can so optimizing things so that we can live that very last part of our life in good health and not frail and not ill.
Exactly. And that's really our entire modi operandi here at VO is to help people enjoy that final stage of life. And I know we all have read Dr. Peter Attia's book about, outlive and living longer, but not just living to live better. And it's so important. Um, so I just want to do a quick recap while you guys are getting your questions in. Feel free to type those in here so I can see them. So at VO, kind of some of the things that we've talked about, we do the comprehensive blood panels, the biomarkers, your custom wellness plan, your one-on-one consultation with your clinician, who may be Dr. Miller, and your functional nutritionist, which is just key to help integrate, any kind of deficiencies that you might observe in your blood work. You're able to help address with food first before supplementation, even when it's possible. And these coaching staff that we have is just amazing. They work with people just one on one and meet them where they are, understand what they need as far as motivation or push or, just kind of a person to talk to along the way as they're discovering all of this about their bodies. Everything lives on a comprehensive dashboard, which I think a lot of people really enjoy. You can connect with our community there. You can connect with your wearable data. You can really track how your sleep actually did, or maybe you're wearing a continuous glucose monitor, and you can see how that tracks with your nutrition and everything that you're doing with Cindy. So it's really a holistic approach to health in a way to hand all of this information back to you so that you can be the one that's in charge again, which is really the way it should be. Um, we actually have HRT now available in Kentucky and Georgia with Dr. Miller. There's some more information that you can get if you sign up for our newsletter, and the pricing is really reasonable. And I think the biggest benefit to this is working directly with Dr. Miller one-on-one. So I might even let you just kind of, I think that was a question that was going to come through, is kind of how you prescribe HRT, Dr. Miller, when it comes to like meeting a patient and then kind of understanding their symptoms and then how you go through that process with them. Maybe you could just walk us through that before we get to the actual Q&As because it kind of lines up with this.
Yeah, so, finding out the symptoms, number one, as far as like what's going on, the history, number two, personal history of breast cancer, heart disease, kind of looking at those risks. And then looking at labs as far as like where we are, just as that baseline knowledge, testosterone labs and estrogen, and then I say customizing, but that, there are different preparations of estrogen, progesterone, testosterone. So you can start them all together, start them one at a time. So in somebody that has a lot of side effect medications, I'll do what I call stacking, where they'll start one at a time just to watch closely to make sure we know if they have a side effect from the medication. I go with the bioidentical estradiol, bioidentical progesterone, and we know that estrogen, has fewer risk if used transdermally, and side effects as well. And what I mean by that is a form of like a patch, a gel, a cream. And the reason is it doesn't go through our liver, and so it's not going to affect our clotting factors and therefore not affect DVT or stroke risk. It's also not going to decrease our testosterone level if we use it transdermally. So I usually start with that with estrogen, and then again, depending on the symptoms, your age, like we'll kind of determine the dose, and then progesterone bioidentical. It's a capsule that you take at night that's going to help so much with sleep. And then testosterone primarily, for low libido, which our libido is complex. And so we always have that conversation. You know, other areas that we can work on to improve libido. There are other medications that are FDA approved as well, but testosterone can be helpful there.
Awesome. Thank you. So now we will open it up to your all's questions, and I'm just going to read these off to you. So we've got, because visceral fat and insulin resistance are such a factor in midlife weight gain, what are your thoughts on using GLP-1s?
Well, I'm a big fan of GLP medications. It's not an easy fix though, or answer to weight loss. And I always like, I mean, it seems like an easy fix because you get on them and you lose weight. I mean, it's really great, but when you get off of them, guess what happens? You gain weight. That's what the data shows. The majority of patients, the weight that they lose with the GLPs, they will regain when they go off. And so it's not as easy as just take it, it's going to be great. I mean, it is because it really helps the food noise. It has several mechanisms of actions, and one of the way it works is like that kind of craving that we have. It's like, do I want that chocolate or do I want an apple? Well, I think, do I even want to eat it all? Okay, I'm going to pick that apple. It's really like simplifies things. The cravings, the noise just disappear. So it's very empowering. And, we have patients that have chronic obesity also try to really kind of reframe this obesity that it's not a willpower thing. It's not a shame thing. If you struggled with this, for your life. This is a disease process that's complex. Genetics, environment, hormones, like there's just it's a complex process and it's a disease state. And we should see it as that. Insurance companies should see it as that. And they should cover medications to treat that disease process. And so, those patients that have a significant amount of weight to lose, then I think, it's a lifelong commitment. And that's okay. Just like we might take a blood pressure medicine. For those of us that maybe it's like more like, okay, I'm just gaining this weight really slowly. Now I've got 10, 20, 25 pounds. And I think, again, deep dive into each of those pillars for weight, and that sleep, stress and cortisol levels, nutrition and movement and strength training. And we just do a real in-depth kind of talk about those pillars. But GLPs, if you've tried those things and it's leading to this frustration, and it can be a really great way just to kind of initiate, get that weight loss going. And, what I do with patients is use a really low dose, go up really slowly to minimize the side effects, and then, taper you off, space it out. I'll have some patients that'll take it just when they're like in their luteal phase, or when they have a time of stress where they're like, okay, I'm going to go back on for a little bit. I've made some bad choices. So I've had patients be able to wean off, wean down, and do quite well.
Yeah, it's so interesting how much it helps with the cravings. Not so much like the weight's going to drop off, but it like helps you. I feel like I've heard so many people say make better choices. So, and a follow-up question to that was if we prescribe GLP-1s, and not at the moment, but we do have several members that are on them, and we definitely try to monitor pretty closely with nutrition and following along with their body scans to make sure that we're not losing muscle mass as we go. So we want to pay really close attention to that. Not that it's really under our care, but that's something that we advise people about for sure. And then Susan wanted to know what the book was that we referenced. I think that's going back to Peter Attia's book, Outlive. I think that's the only book I've mentioned. I don't know about you, Kelly. So he's our godfather of longevity, or just a great talking head to listen to. He was actually just on 60 Minutes last night. So if you have a chance to watch that recording, his book is a must read over at VO. It talks about the centenarian decathlon. So the 10 exercises that you can be doing now so that you can live your most full life when you're older. So it might be exercises that make it so that you can lift a suitcase up in an overhead bin, and travel when you're 75 instead of being, sitting in the recliner. So definitely take a look at him, and his podcast called The Drive is fantastic too. Next from Suzanne, there's a lot of emphasis on plant-based diets for disease prevention. Is there also evidence of increasing protein needs to maintain muscle mass and bone health? Thoughts on the best approach and best foods
Yeah.
for menopausal symptoms?
Yeah, I think that's a great question. And I think, you don't want to jump onto any like kind of fad thing. Like, and I don't like to ascribe to a certain way of eating as that's the best way. I think it's individual, right? Like, is it good to be a vegetarian and eat a bunch of carbs? Is it good to be a carnivore and eat all red meat? No. The data, though, is as far as cardiovascular health, it's Mediterranean, and that's not total vegetarian. Fish, poultry, maybe you do grass fed, maybe you do bison, ground turkey. I'm not saying that you shouldn't eat any red meat, but definitely, mostly plant based, adding in lean proteins. And I was talking to a patient today who's vegetarian about plant-based sources of protein. And Cindy, who's our nutritionist, is really excellent. And I always tell patients after our physician call, make sure you have specific questions for Cindy. Like if you're a vegetarian, like I want to know how I can get my protein best as a vegetarian. And she is going to put that meal plan together with you, around that. Things for menopause are going to be those phytoestrogens. So like edamame, soy, and miso um, are going to help the best. But it is kind of hard to tackle menopause symptoms as far as the vasomotor symptoms with food. Just not enough.
Great. And then we've got Jen who started HRT at the end of August, and she hasn't noticed any significant changes. How long does it take to notice changes, or if it's working for you? Should I get more
Yeah.
detailed lab work or check my levels?
Yeah. So some thoughts on that. 2 months. I don't see patients back before 2 months when I start hormone therapy because it does really take some time. And it also depends on which menopause symptom. With hot flashes, sweats, you should see that right off the bat. With sleep, almost right off the bat. Joint pain and that inflammation and weight and body composition is going to take a little longer. So it depends on the symptom. Now that we're using a lot of transdermal estrogen, that is a place to then follow up hormones, meaning if I have a patient come in at 2 months and they're like, I'm no better. So one option would be, well, let's increase dose depending on what we started you on. A second option would be, let's check levels just to make sure that you're absorbing what you're rubbing on your skin. Like a common thing that patients will do that I tell them beforehand, but if they're using that Diva gel, which is an estrogen gel on their forearm, they'll use their fingers and put it on their forearm. And then guess what they do? They wash their hands. There's so little in that Diva gel packet or in those gel packets that you're washing the majority of it off. So then kind of counseling around that. So, but to answer your question, 2 months for sure.
Okay. And then one of our guests missed what you were saying about bioidentical estrogen and estradiol patches and why you recommend those and prescribe those.
Yeah, so the estrogen that's been around the longest since the 1940s actually comes from pregnant mare's urine. That's the conjugated equine estrogens. And they got a bad rap in the Women's Health Initiative, and we've just moved more, to the bioidentical estradiol. It's, in bioidentical, I use that word, although it's more of a marketing word. Like it's a, because it's not like we're chopping up ovaries and getting that hormone out and giving you some, it's not how it's done. It is, made by semisynthesis in the lab, and but it is from a plant base, from soy mostly, and but it is molecularly identical to what estrogen that our ovaries make. And so we start, or at least I do, transdermally because of the safety profile. It's not going through the liver. It's not going to increase DVT or PE, which are blood clots risk. It's not going to increase those clotting factors.
Okay, great. And then a follow-up is how long is it safe to stay on HRT and kind of how do you monitor that?
Yeah, great question. To continue HRT, there's really no age like, oh, I'm 71, I must stop. It's dangerous. We don't have data that says at a certain age it's dangerous. It's a shared decision making. It's a risk benefit profile every year that we look at. And probably the biggest study came out last year, I believe, maybe it was 2 years ago. But it looked at 10 million women actually that were 65. One group had been on hormones for over a decade. The other group had never been on hormones, and they actually saw that protection in their brain and their heart, and their bone health, and no additional risk in the women on hormones. And so that data for sure, I just you can continue hormones. I hope I can stay on mine forever. If you unfortunately develop breast cancer and estrogen dependent cancer, if you have a clot, then we have to really back up and reevaluate the safety.
Okay, great. And the questions are slowing down. I was gonna oh, here we go. Does estradiol cream impact liver enzyme levels?
No.
And that's because it's transdermal. You got
Yes.
it down. Yeah. And one thing that you said actually that I had not heard before was that it doesn't decrease your testosterone. So would oral estrogen decrease your testosterone just by nature?
So what oral estradiol, it's just like birth control pills. So what happens is when we're on a birth control pill or an oral estradiol, it is metabolized through our liver, and it's going to increase a protein to be through the bloodstream called sex hormone binding globulin. So that level goes up, and it does just what it says it does. It binds up sex hormones, meaning testosterone and estrogen, and it therefore kind of renders it ineffective. And so, most of us don't really want, lower testosterone or ineffective testosterone. So it's not that you can't use oral estrogen, and some women, they're not having issues with that, and they want to just kind of see they like taking a pill. And it's still, I don't mean to give oral estradiol a bad rap, because I definitely had probably 2 or 3 patients on it today. They like it, they like taking a pill, and I just it is okay, but that's what you'd want to watch for.
Okay, great. And then I know we had a question earlier about taking like supplements instead of doing HRT or kind of as you're going into perimenopause before you think you're ready for HRT.
Mhm.
How do we address that? Because they're just very different.
Yeah. Well, I'm a big fan of, I took my little container of supplements. In fact, I think I have it over here somewhere. That's how I best remember it today. So, I am a big fan of some supplements. We're definitely food first, and I'm definitely all that way with my, nutrition. But there are a couple supplements that's really hard to get great in our diet. And that impact our health. For perimenopause women, I actually talk a little even more about supplements, because they may not be ready to commit to hormone therapy. Because this may be, I mean, for some of us, a lifelong commitment. And it's like, do I want to go ahead and start this when I'm not having a lot of symptoms yet? And so, but I'm not sleeping the best, but my moods. And so, in that population, for sure, trying whether it be magnesium, or, another one that's kind of big is how do we help this cortisol from our chronic stress that we have. And, there are a couple supplements that can be like adaptogens mainly, that can be helpful in that area too.
Yeah. And I think some of them that you've talked about, like ashwagandha, L-theanine, and then I think some people say like lion's mane might be some of those kind of mood leveling. Okay. And then Crystal wanted to know, she was prescribed HRT patch, but how does she know if it's bioidentical?
So all patches, except I'm trying to think what the name of the one, combo patch. I mean, the majority of if you're on an estrogen patch, it is very likely a bioidentical estradiol. And just look at the box. It should say, it probably won't say 17 beta. It should say estradiol, not conjugated equine estrogens.
Okay. And then, Amy, did we answer your question? Some of those supplements I think that we were talking about would be that ashwagandha, L-theanine, probably magnesium. And actually, Kelly, do you want to talk about the different types of magnesium for different purposes?
Yeah. Yeah, I think, one of the things we do too is just make sure when you go buy supplements that you're not just like, I don't know, you want to make sure the supplement company that you're using is like third party tested and, that you're just getting a real good quality because, it's a little wild west too in the supplement industry, right? Like people want you to buy their stuff and nobody is really overseeing that as far as the quality and purity or you getting what you think you're getting. And, so there's that. Magnesium, I'm a big fan of, well, for a lot of reasons. So people that have constipation, our motility slow as we age, that magnesium citrate form, people that are on GLPs, I really love that form. I love magnesium glycinate for the perimenopause that just wants calming and sleep. I love that form. I love magnesium threonate for those of us that are aging and worry about like cognitive decline. It's the only form that crosses the blood-brain barrier. And I've had some patients notice even an improved form. So yes, the type does matter.
Okay, great. And that's why we at VO we used full script. So they've already third party tested all of those supplements that we would ever recommend. And we try to kind of help people sift through all the different things that they might be taking or might have seen on Instagram or something and help them understand what they actually need for their body. Okay, her estradiol patch was a Milan,
Hmm.
Mylan. You're good. Way to go.
Yep.
You're good. And then Susan, about 3 years postmenopause and not on HRT or MRT. She did the estradiol patch and was told to stop. Does postmenopause and end, and how do I know it's over? And she's looking forward to exploring some options with you.
Yeah,
Looks like
it's
you
never
committed
really
very
over,
well.
right? I mean,
Yeah.
it's over when we die. Like that's the thing with menopause that I feel like so strongly that that's why I did a talk with physicians not long ago. Like, hopefully we're all going to enter menopause if we live long enough, right? We're going through it. We spend an average 40% of our lives in menopause. It's not necessarily going away. Now, that doesn't mean the symptoms aren't going away, some of them, right? Like vaginal dryness is not going away. Pain with sex, UTIs not going away. Joint pain not going away, but hot flashes on average last 7 to 8 years. So it depends on the menopause symptom as far as like, is it going to go away or not? That's going to last about 7 to 8 years. So, we're not really through it ever. We're in it, for the long haul. That's just us. It's our new way of being, which I think it's a really great time period. But should you stop hormones? Again, if you had a risk, if you had a DVT or a PE, if you develop breast cancer, yeah, you've got to stop it. If you are going through something that puts you at such high risk of a stroke or a heart attack that we decide together, looking at your full history and your symptoms, that it's better if you not be on it, then you should probably stop it. To say you should stop it, it's been 3 years, it's time, is nonsense. That's bad counseling.
Okay. And we're going to jump back to magnesium. If you needed all of the benefits that you outlined with the three different types of magnesium, would you choose one or would you alternate between the different types? What do you think?
There's some companies like BioOptimizer that they'll do like they'll make multiple magnesium forms in the supplement. So you can do a little blend and like I had a patient today and I can't remember exactly but I was like take 200 of citrate and 200 of glycinate to get to 400 nightly. So we kind of came up with a little cocktail for her today based on her symptoms. So you can mix and match that a little bit.
Okay, great. And what are your thoughts on Nutrafol for hair shedding and thinning?
Okay, so the data, because I'm a data gal, but I always like the disclaimer, like, okay, data free space or whatever, but the data does not show it works. However, like I had literally two patients today that were singing its praises. So what I tell patients, you know what, maybe you should try it. The pills are big, it's expensive, but I don't think it's going to hurt to try it because we're kind of desperate with our thin hair and like what can we do? And so I don't think there's anything wrong with trying it.
Okay, fantastic. Are there any other points that you feel like we didn't get to or that this is kind of making you think about after reflecting from coming back from the seminar?
No, again, highlight sleep, lifestyle, finding someone that will really, again, anticipatory guidance in perimenopause years, finding someone that will listen, comprehensive approach, getting a team really, a whole supportive team on your side to help you. Um, Key.
Okay. And I think it'll be exciting too. Hopefully, for our next one, we'll be talking about our longevity fest that we're going to in Vegas in a couple of months, learning more
Yeah.
about longevity medicine so that we can add that onto women's health. So if we are out of questions, I think we're going to jump on through here. And I'll keep that up. If anything pops back up, I will try to address it as well. So if anybody's not already a member of VO and you want to learn more, you can scan this QR code or go to this website here, Partners. You can request a call, more information, talk to one of us, or just go ahead and join. And you can actually use my personal discount code at checkout if you're interested in starting now for 20% off. So that's my thank you to you. If anybody wants to reach out, feel free. And Dr. Miller, I just want to say thank you so much. It is a
Of course.
pleasure doing business with you and being on this journey with you. I just couldn't be more thrilled that you wanted to be a part of this team and are helping us and helping all of our female members just really thrive at every stage of their life. And it means the world to all of us. So thank you so much for everything you do.
You're welcome, Miss.
All right.
Ready, have a good night.
Thanks, everyone. We'll talk to you
Bye.
soon. Bye bye.